Hello everyone, this is Dr. Priyankita Nath, your faculty for anatomy, and I am going to start the image advantage series. So this series is basically a compilation of all the image based questions asked in the recent NEET PG and the MCQ. So without any further delay, let us start. Okay, so the first question, a patient who came to the OPD showed the following gait in the given picture. Now, what is being examined at the hip joint? So, the options are adduction, flexion, extension, and abduction. So, this gait refers to a typical gait which we have to learn and a typical sign which are very commonly asked in most of the exams. So, it is the Trendelenburg sign. Okay, Trendelenburg sign, and the gait is the lurching gait. Okay, now what is Trendelenburg sign positive? So to understand that, let us understand a basic concept. Okay, this is a normal pelvis. Okay, normal pelvis when both the foot are off the ground, both sides gluteus medius and gluteus minimus is contracting. Okay, when the foot is off the ground, then our both side medius and minimus is contracting and it is keeping the pelvis in a same level. Now what happens if the foot is off the ground? One of the foot is off the ground. Say the left foot is off the ground, then the gluteus medius and the minimus of the right side will contract. Okay, and it will prevent the pelvis from sagging down. Okay, it will tilt the pelvis up, but it will prevent the pelvis from sagging down. What will happen if there is paralysis of the gluteus medius and minimus of the right side? So what will happen? Then the pelvis will tilt down or sag down, and this sign is known as the positive Trendelenburg sign, and the gait is the lurching gait. Okay, so if there is paralysis of the gluteus medius and minimus of the right side, then there will be tilting down or sagging down of the pelvis on the opposite side. Okay, so that is about the Trendelenburg sign, positive, and the gait. So in this image, as you can see, that this is the normal pelvis. Okay, and there is tilting down of the pelvis on this side. If there is tilting down of the pelvis on the left side, then the right side muscles are paralyzed. Okay, and the gait is the lurching gait. Now we have to also understand the abductor mechanism of the hip joint. So there are three things. One is the power, another is the weight, and the other thing is the fulcrum. Okay, now in this case, the fulcrum is the hip joint, the power is produced by the gluteus medius and minimus, and the weight is given by the head and neck of the femur. Any disruption of this mechanism will lead to your Trendelenburg sign, positive. Okay, any disruption of this abductor mechanism will lead to Trendelenburg sign, positive, leading to your lurching gait. Okay, leading to your lurching gait. One more thing I want to concentrate in this entire topic is the gluteus medius and gluteus minimus. They are the chief abductor. Okay, abductor, chief abductor of hip joint. Okay, they are the chief abductor of hip joint. And what about gluteus maximus? So gluteus maximus, it is the chief extensor of hip. Okay, it is a chief extensor of the hip joint. So medius and minimus, they are the chief abductors of the hip joint, and maximus is the chief extensor of the hip joint. Now the question may be asked in the other way around. So you have the gluteus medius and minimus, they are supplied by your superior gluteal nerve. Okay, and maximus is supplied by your inferior gluteal nerve. So they might ask the question in the other way, like if there is injury to the superior gluteal nerve of the right side, then the sagging of the pelvis will be on which side? So the sagging of the pelvis will be on the left side. So this gait is the lurching gait. That is a positive Trendelenburg sign, and it is found in unilateral paralysis. Okay, it is found in unilateral paralysis of gluteus medius and minimus. So unilateral paralysis of gluteus medius and minimus supplied by your superior gluteal nerve. Okay, so there will be injury to the superior gluteal nerve unilaterally. Then the gait is the lurching gait. If there is bilateral paralysis of gluteus medius and minimus, bilateral, both right and left, then the gait is known as your waddling gait. Okay, waddling gait. So waddling gait is like the gait of the duck. Okay, so lurching gait, unilateral paralysis of gluteus medius and minimus, and waddling gait, bilateral paralysis of gluteus medius and minimus. Okay, so let us come to the question. So they have asked the gait and what is being examined in the hip joint. So you know that at the hip joint, what we examine is the abduction, abduction, and the gait is the lurching gait. Okay, and the muscle is gluteus medius and minimus. Very easy. Okay, let us come to the next question, the question of CNS. So they have given a cadaveric image, and I asked to identify the mark structure. The options are globus pallidus, claustrum, external capsule, and internal capsule. So before attempting to answer this question, let us study a little bit about the basal ganglia and internal capsule. So what are basal ganglia? Those are the subcortical gray matter, and they include the caudate nucleus, lentiform nucleus, which is composed of your putamen and globus pallidus, amygdaloid nuclear complex, and claustrum. So as you can see here, these are the subcortical gray matter. This is the head of the caudate nucleus. Okay, you can see the thalamus here. These are the lentiform nucleus, okay, which is the putamen and the globus pallidus, and then you have the claustrum. So these are the subcortical gray masses. Okay. Now in this image, as you can see, if you can correlate this. Okay. So same thing, just we have studied. This is the head of the caudate nucleus. Okay. And then you can see the lentiform nucleus. This entire thing is the lentiform nucleus. Okay. So you have the putamen and the globus pallidus, and then a very thin layer of gray matter, that is the claustrum. Okay, that is about the basal ganglia. Now let us study a little bit about the internal capsule. So these are the white matter, subcortical white matter, and it has the following parts. So they are the anterior limb. This is the anterior limb. Then there is a band, that is the genu, and then you have the posterior limb. Okay, then you have the sublentiform and the retrolentiform part. Okay, you have an internal capsule and you have an external capsule. Internal capsule is also white matter, external capsule is also white matter. Now if we come to this scan, okay, if we come to this scan, you can see a slightish area here. This is the internal capsule, anterior limb, genu. This is the anterior limb, genu, and posterior limb. Then you have the gray matter here. This gray matter is the lentiform nucleus, and then you will have another white matter here, that is the claustrum. Okay, and after the lentiform nucleus you will have another capsule. This capsule is the external capsule. So as you can see here, this is the anterior limb of the internal capsule. Okay, and this is the posterior limb and genu, and then you will have the nucleus here, and that nucleus is the lentiform nucleus. So if you see this image again, this white matter, it is the internal capsule. Okay, you have the anterior limb, you have the posterior limb and the genu. This is the lentiform nucleus. So you will have the globus pallidus and the putamen. Then you will have another thin layer of gray matter, that is the claustrum. Okay, that is the claustrum, and in between this you will have another white area. Okay, another white area, and this white area is the external capsule. Okay, it is the external capsule. Okay, I think it is clear to you now. So the marked area is the anterior limb of the internal capsule. Anterior limb of the internal capsule. Okay, next question is also related. So they have shown what is the role of the mark structure in the given image. Now you can see here, those are the gray areas, and these are the gray areas which are the lentiform nucleus. Okay, the lentiform nucleus of basal ganglia, and the main function of this areas is your motor function. Okay, the main function is the motor function. So as you can see here, this entire area is the lentiform nucleus. You have the putamen, you have the globus pallidus, then you have another area of gray matter, that is the claustrum. In between the lentiform and the claustrum, this white area which is shaded by yellow, that is known as the external capsule, and between the head of the caudate nucleus and thalamus below, you have another white layer. This is the internal capsule. Okay, so I hope this question is clear to you. And the basal ganglia, as you know, it is mostly related with your motor function and voluntary movement. Yeah, so the answer here will be your motor function. Now the next question, a person was climbing the stairs, there was no light, so he suddenly fell and hit an iron nail at the posterior triangle of the neck. After the injury, the person had difficulty to elevate the shoulder and presented with loss of shrugging on the side of the injury. So which structure is most likely to be damaged? They have given the option deltoid, accessory nerve, sternocleidomastoid, and long thoracic nerve. Okay, and they have also given the image there. To attempt this question, let us understand a little bit about the posterior triangle. So you know the boundaries of the posterior triangle. Medially, it is formed by the sternocleidomastoid. Okay, laterally you have the trapezius, and the base is formed by the clavicle. So in the posterior triangle, you have this nerve, that is the spinal accessory nerve. The spinal accessory nerve, which is supplying both the trapezius, it is supplying both the trapezius and the sternocleidomastoid. Okay, now what will happen if there is injury to the spinal accessory nerve? The trapezius has three fibers. One is the upper fiber, one is the middle fiber, and one is the lower fiber. Upper fiber, it will help in elevation of the scapula. The middle fiber will help in your retraction of the scapula, and the lower fiber will depress the scapula. So this entire trapezius muscle is involved in the scapulohumeral rhythm. So if there is injury to the spinal accessory nerve, so you know that the shrugging of the scapula, that is shrugging of the shoulder, will be lost. Okay, so the answer here is your spinal accessory or accessory nerve. Okay, now the next question is a histology slide. So they have marked these cells, okay, and they have asked the mark structure secrete which hormone. Okay, so this is a typical slide of your thyroid gland. These are the colloid. Okay, colloid, and these are the follicular cells. And the cells shown here, these cells, what is this cells? These are the parafollicular C cells. Okay, parafollicular C cells. They will secrete your calcitonin, and calcitonin will decrease the serum calcium levels. So the answer here will be your calcitonin. Okay, the mark structure will be the parafollicular cells which secrete the calcitonin, and it decreases the serum calcium level. So same thing you can see here. These are the thyroid follicle, colloid. Okay, and these are the follicular cells, and these are the parafollicular C cells. Parafollicular C cells. Okay. The next question is, what is the blood supply of the structure marked in the image below? And they have given the option, the middle cerebral and the posterior cerebral artery, anterior cerebral and anterior communicating artery, anterior cerebral and middle cerebral artery, and anterior cerebral and posterior cerebral artery. So they have given an image, they have put a pointer on that structure, and they have asked the blood supply of the structure. So first of all, let us know what is this structure. So this structure is the corpus callosum. These are commissural fibers, okay, connecting the two cerebral hemisphere, and it has certain parts. So you have a first part here. Okay, before going into parts, you should get oriented with the image. Now, as you can see the cerebellum, so this is the posterior and this is the anterior. Okay, so from anterior to posterior, you have the rostrum. Okay, then you will have a bend, and this bend is the genu. Okay, then you will have the body of the corpus callosum, and the last part is the splenium. Okay, from anterior to posterior you have the part that is the rostrum, then a bend, that bend is the genu, then you will have the body, and then you will have splenium. So now you know that this is the commissural fibers connecting the two cerebral hemisphere. Now what is the blood supply of this corpus callosum? So to understand that, you should also know about the arterial supply of the cerebral cortex. So on the superior lateral surface, the upper marginal part, okay, this part is supplied by your anterior cerebral artery, okay, and the entire part is supplied by your middle cerebral artery, and posterior little bit part is supplied by your posterior cerebral artery. This is about the superior lateral surface. If you go to the medial surface, then most of the part is supplied by your ACA, and lower part is supplied by PCA, posterior cerebral, and little bit around a temporal region will be supplied by the middle cerebral artery. On the inferior surface, most of the part is supplied by the posterior cerebral artery. Okay, on the orbital surface, if you see, the medialmost part is supplied by the anterior cerebral artery, and the lateral part is supplied by the branches of the middle cerebral artery. So in this image, this section is a medial, they are showing the medial surface. So you know that the medialmost part is mostly supplied by your middle cerebral. No, it is mostly supplied by your anterior cerebral artery. Okay, it is mostly supplied by your anterior cerebral artery, and middle cerebral is supplying your superior lateral surface. Okay, if the question comes on the superior lateral surface, so you should know that most of the arterial supply is the middle cerebral artery, and on the medial side, the entire arterial supply is by the anterior cerebral artery. Okay, so what happens, this anterior cerebral artery, okay, it gives branches around the corpus callosum, and these branches are known as the callosal branches. It will also give certain branches above, those are known as the pericallosal branches, and you will also have a small branch that is the anterior communicating artery. So this entire part of the corpus callosum is supplied by the branches coming from the anterior cerebral artery, that is the pericallosal and callosomarginal branches. Okay, So one of the option is the anterior cerebral artery and the other option is the anterior communicating artery. Okay, so the answer will be anterior cerebral and the anterior communicating artery. Okay, medial surface, mostly entire part is supplied by your anterior cerebral artery, and since it is corpus callosum, these branches are the pericallosal and callosum marginal branches, and you will also have a small branch from the anterior communicating artery. Okay, small branch, that is anterior communicating artery, and anterior cerebral artery will supply your entire part of your corpus callosum. Okay, the next question is identify the mark structure. So they have given a cut section, a transverse section, okay, and they have put one arrow and asked to identify that. So you should know this is, as you can see, the structures here. This is the kidneys. Okay, first you get oriented, as you can see the vertebra. So this is posterior, this is anterior. Since you can see the kidney, it is mostly at the level of your T12, T12 L1. So you can see the kidneys, you can see the liver. Okay, this is the stomach. This is spleen. Now they have asked about this ligament which is connecting the kidney and the spleen. So connecting the kidney and the spleen, the ligament is your lienorenal ligament. If they would ask about this ligament which is connecting the spleen and the stomach, this ligament is known as the gastrosplenic ligament, as the name suggests. So the answer here will be the lienorenal ligament. So as you can see this image again, liver, just now we have studied the liver, the stomach, the spleen, the kidney. Okay, you have one more ligament here, that is the falciform ligament. Okay, they might ask about the falciform ligament, about the gastrosplenic ligament, and about the lienorenal ligament. Okay, and what is the structure? From the stomach to the porta hepatis, this is the lesser omentum. Okay, so you should know a little bit about the transverse section as well, because any question can come on this. So the answer is your lienorenal ligament. Okay. Next question, identify the nerve passing around the mark structure. So they have given femoral nerve, tibial nerve, common peroneal, and sudal nerve. So now you know that this bone, this is tibia, this is fibula, and they have asked the part surrounding the neck of the fibula. Okay, so what is the structure surrounding the neck of the fibula? You know that structure is the common peroneal nerve. Now common peroneal will divide into your superficial peroneal and deep peroneal. The superficial peroneal will mostly supply the anterolateral aspect of the leg, and the deep peroneal will supply the anterior compartment or the extensor compartment. So injury at the neck will lead to the injury of the common peroneal nerve, and if there is injury to the common peroneal nerve or the deep peroneal nerve, then there will be loss of your dorsiflexion. Loss of dorsiflexion, and that condition is known as your foot drop. So inability to lift the foot, front part of the foot off the ground, that is your foot drop, and there will be loss of dorsiflexion mainly due to injury at the neck of the fibula due to injury of the common peroneal or the deep peroneal nerve. So the answer here will be your common peroneal nerve. Very easy question. So next question, they might ask same type of question in an X-ray. So they have asked injury at which of the following mark site causes failure of dorsiflexion. So just now we have studied that this failure of dorsiflexion is due to injury to the common peroneal around the neck of the fibula. So around the neck of the fibula, that is option C. Okay, so in this X-ray, you know, this is the head of the fibula, this is the neck of the fibula. They have also marked the lateral condyle and the tibial tuberosity. So you know that around the neck of the fibula you have the common peroneal nerve, and injury to the common peroneal nerve will lead to your failure of dorsiflexion. Next question, which mark structure causes lateral rotation, flexion and abduction at the hip joint and flexion at the knee joint. So they have marked the muscles of the anterior compartment of the thigh, and they are asking that out of this, which muscle is causing your lateral rotation, flexion and abduction at the hip joint and flexion at the knee joint. So all these things are done by the talus muscle, that is your sartorius. Okay, this muscle, which is starting from the anterior superior iliac spine and inserting on the medial surface of tibia, that is your sartorius, and the option is your 1. So the answer here will be 1. Sartorius. Okay. So as you can see, those are the anterior compartment muscle. This is the sartorius. Okay. Then you also have the floor of the femoral triangle, that is the pectineus, the adductor longus. On the medial side, you can see the gracilis. Okay. And the adductor magnus. And on the lateral side, you can see the tensor fascia lata, and this entire bulk is your rectus femoris. Okay, rectus femoris. So those are the muscle of the anterior compartment, and sometimes they might ask you about the nerve supply. So to remember the nerve supply, you just see the section of the facial compartment of the thigh. So the anterior compartment is supplied by femoral nerve. So the nerve supply of the sartorius will be your femoral nerve. The medial compartment is supplied by the obturator nerve, and the posterior compartment, the entire muscle group, is supplied by the sciatic nerve. So anterior compartment femoral, medial compartment obturator, and posterior compartment sciatic nerve. Okay. The next question, the dermatome of the marked area with an arrow. So first of all, you get oriented. This is anterior, this is posterior. Now, as you can see, this is the hallux. Okay, so this is the medial aspect, and this is the lateral aspect. Okay, now medialmost part is dermatome they are asking. So after getting oriented, you have to remember about the dermatome. So in this one side, the images of cutaneous innervation, and the other side is of dermatome. So as you know, in the leg, okay, the leg, the medial aspect, the dermatome is L4. Okay, then you have the L5, and on the posterior aspect from medial to lateral you have L4, and in between you will have the S2, and on the lateral aspect you will have the L5. So medial aspect will be L4 and lateral aspect will be L5. Okay, and if they are asking about the nerve, so that nerve will be your, what will be that nerve? That nerve will be your saphenous nerve. Okay, so medial aspect saphenous nerve. On the lateral aspect you will have the superficial peroneal, one half, and upper half you will have the lateral cutaneous nerve of thigh. Okay, so the correct answer will be your L4. Okay, this will be L4, this will be L5. As you can see, this is L4, L5, and below you have the S1. Okay, from medial to lateral if you go, L4, L5 and S1. So that is about the dermatome. Now, the first web space of the foot is supplied by common peroneal, superficial peroneal, deep peroneal, and sural nerve. So if you see the web space here, this is the first web space, and the first web space is supplied by the deep peroneal nerve. Okay, the first web space is supplied by the deep peroneal nerve, and above that entirely all the lateral aspect is supplied by the superficial peroneal nerve. The medial aspect is supplied by the saphenous nerve. Okay, and the tip, if you see laterally, lateral plantar, and medially you will have the 1.5 finger by medial plantar. So the first web space is supplied by the deep peroneal nerve. If you see the dermatome of the foot, you can see that most medially you will have the medial plantar, laterally you will have the lateral plantar, and on the heel you will have the medial calcaneal branches of the tibial nerve, and most laterally you will have the sural nerve. And this is the dermatome from medial to lateral, L4, L5 and S1. Okay, so the answer will be the first web space is supplied by your deep peroneal nerve. Okay, next question is again one of the histology slide, very easy and repeated slide. So which of the following is a function of the marked area? So they have given increased sex hormones, immune cell interaction, sodium and water retention, and gluconeogenesis. Now looking at the options, you can think about one single slide which has the component GFR, okay, and that is present in the adrenal gland. Okay, just looking at the option, okay, even if you don't get the slide, just looking at the option you can identify that it is a slide of the adrenal gland. So this is a slide of the adrenal gland, and they have marked it on the zona glomerulosa. Okay, they have marked on the zona glomerulosa. So let us study a little bit about the slide. So you know that the adrenal gland has a zone internally, that is the medulla, and outer zone, entire part, this is the cortex. Now this cortex is again divided into zona glomerulosa, fasciculata, and reticularis. Okay, as you can see here, from outside you will have the glomerulosa, then you will have the fasciculata, and then you will have reticularis, and then your inner side you are going to have the medulla. Now this three components, that is zona glomerulosa, zona fasciculata, and zona reticularis, just try to remember salt, sugar, and sex. Okay, salt for the mineralocorticoid, sugar for the glucocorticoid, and sex hormone for the androgens. Okay, these are the things which are secreted from those zones. And medulla, adrenal medulla, mostly the stress hormone which will stimulate the sympathetic ANS, that is the adrenaline or epinephrine or norepinephrine, or adrenaline and noradrenaline. Okay, so these are the things which are secreted by each zone. The innermost is the adrenal medulla, so adrenaline, noradrenaline, and then you will, from if you go from inner to out, that is reticularis, fasciculata, and glomerulosa, or out to in, that is GFR. Okay, that is GFR. So in this question they have marked the outermost structure, this area. So this is your zona glomerulosa. So we know that it is secreting your mineralocorticoid, mineralocorticoids. So those are mostly involved in sodium and water retention. So the correct answer is sodium and water retention. Even without looking the slide, you can know this trick, that it is a slide of adrenal gland. Just see the options. Mostly they are given about salt, sugar, and sex hormones. Okay, so mostly salt for mineralo, and this is for sugar, that is for your fasciculata, and increased sex hormone, that is for your reticularis. Okay, and the immune cell interaction, that is for your adrenal medulla. So just looking at the option, you can identify that it is a slide of your adrenal medulla, and then you see the marked arrow. Okay, that area marked is your zona glomerulosa. So if you remember about the adrenal gland, you will immediately remember GFR and SSS. Okay, salt, sugar, sex hormones. Okay, so that is about the trick to remember about the adrenal gland histology slide. Okay, next question. A baby was delivered by an obstetrician by pulling baby's head using forceps. So it was a forceps delivery. 2 weeks later, the parents took the baby to the pediatrician for checkup. While examining, the pediatrician found baby's arm medially rotated, adducted, while his forearm was extended and pronated. He also noticed sensory loss on the lateral aspect of the right upper arm. What is the cause of the sensory loss in the upper limb? So they have given involvement of ventral root of C5 and C6 spinal nerve, dorsal root of T1 of spinal nerve, again dorsal root of C5 and C6, and ventral root of T1. So if you see this typical sign, okay, so this is your medially rotated, adducted, right? And it looks like policeman is asking a tip. So this is known as policeman's tip sign. Okay, policeman's tip sign. And this is found in a condition known as Erb's palsy. So before attempting that, we should also know a little bit about the brachial plexus. So brachial plexus is mostly by the ventral rami from C5 to T1. Now, there are different divisions. You have roots, you have trunks, you have divisions, cord, and branches. Now, C5, C6 will join to form the upper trunk. C7 is forming the middle trunk, and C8 and T1 is forming the lower trunk. Now, in the upper trunk, there is a point which is known as Erb's point. So, what is Erb's point? So, as you can see, there are branches coming from the trunk, and those are the two roots, C5, C6. So you have, and also you have divisions. Okay, you have divisions, anterior and posterior divisions. Okay, anterior and posterior divisions. So you have 6 nerves coming through a point that is known as the Erb's point. So C5, C6, suprascapular nerve, nerve to subclavius, and anterior and posterior division. Okay, and this is the upper trunk. So this point is known as the Erb's point. Any injury to the Erb's point will lead to a condition known as Erb's palsy. Now, Erb's palsy, you can see internal rotation of the shoulder, extended elbow, and pronated forearm. And this is known as your policeman's tip hand or waiter's tip hand. It looks like policeman is asking tip or waiter is asking tip. So that's why it is known as policeman's tip hand or waiter's tip hand. So what happens in Erb's palsy? Mostly there is excessive increase in the angle between the head, okay, between the head and the shoulder. So this angle is increased, and this might be increased from a fall from a height or landing on a shoulder, or traction of the arm and hyper extension of the neck, as in forceps delivery. There is traction of the arm and hyper extension of the neck. So this point, Erb's point, may be injured, and it will lead to your internal rotation, extended elbow, and pronated forearm, which is known as the policeman's tip, and it is typical of your Erb's palsy. Okay, Erb's palsy. So let us come to this question. Now you know that Erb's palsy, Erb's point, you have C5 and C6. Okay, 2 nerves and 2 divisions also. So C5, C6 of the ventral rami. So the answer will be your involvement of the ventral root of C5 and C6 nerves. Okay, as brachial plexus is formed by the ventral rami of your C5 to T1. So it will be ventral rami of your C5 and C6 spinal nerve. Okay. Next question. Injury of the lower brachial plexus leads to another paralysis, that is the Klumpke's paralysis. What is the characteristic clinical finding in this lesion? So they have given wrist drop, claw hand, Horner's syndrome, and policeman's tip. So out of all this, policeman's tip, it occurs in the Erb's palsy. So out of this 3, which is the correct one? So let us come to the Klumpke's paralysis. Now, Klumpke's paralysis mostly occurs in injury to the lower brachial plexus. So, what happens in Klumpke's? There will be claw hand due to paralysis of the flexus of the wrist and the fingers, that is C6, C7, and C8, and all the intrinsic muscles of the hand. There will be also hyperextension of the metacarpophalangeal joint due to unopposed extensor digitorum action, flexion of the interphalangeal joint, and there will be intrinsic hand muscle weakness. Also, sensory loss over the medial border of forearm and hand. So, these are the conditions which you will see in Klumpke's paralysis. So, you will see claw hand, and you will also get Horner's syndrome because of the involvement of the T1 sympathetic fibers. So, in Horner's syndrome, there will be partial ptosis, meiosis, anhydrosis, and anophthalmos. As you can see, there will be partial ptosis, meiosis, anhidrosis, and anophthalmosis. So drooping of the eyelid, there will be constriction of the pupil, drying, and also becoming the orbital eye will become small little bit. So you will have both Horner syndrome and claw hand. But out of this, the more prominent clinical sign is your claw hand. So Klumpke's paralysis, you know that it is mostly due to the injury of the, as you know, this is the lower trunk, this is the middle trunk, and this is the upper trunk. So injury to the upper trunk will lead to Erb's palsy in the Erb's point. Injury to the lower trunk will lead to a condition known as Klumpke's paralysis. So you will have claw hand and Horner syndrome. So how this paralysis occur? If there is excessive increase in the angle between the trunk and the shoulder, this angle is more, okay, then there will be your Klumpke's paralysis, sudden upward pull of the arm or arm pull during the delivery. If the arm is excessively pulled during the delivery, then also there will be Klumpke's. So Klumpke's paralysis will be in the lower trunk injury, and Erb's will be in the upper trunk injury. So here the correct answer will be your claw hand. The more prominent feature will be your claw hand. Okay. Now let us come to interesting topic, that is the embryology, and this question has been repeated every alternate years or every year in many exam. So they have asked what is the embryological basis of this following congenital anomaly. So as you can see in this image, this is a typical case of your anencephaly. Okay, anencephaly, and they have given the following option, that is non-closure of anterior neuropore, non-closure of posterior neuropore, non-closure of entire neural tube, and non-closure of the skull bones. So let us study little bit about the neural tube defect. Now this is the developing embryo, and you have two parts here. One is the anterior neuropore, this is the entire neural tube, and then you have a posterior neuropore. So anterior neuropore closes by 25th day and posterior neuropore closes by 28th day. Now what will happen if there is non-closure of this anterior and the posterior neuropore? You will have conditions known as neural tube defects. Now what will happen if there is failure of closure of your anterior neuropore? You will have a condition that is the anencephaly, where there will be no development, like the brain and the skull bones are not developed properly and the brain is exposed outside. So this is anencephaly. Then you might have enencephaly, that is you will have poor development of the occipital bone, and then there will be retroflexion, okay, retrograde flexion or retroflexion, and then you might have another condition that is known as the encephalocele. What happens here? The skull bones are not developed, so the contents of the brain will bulge out. Okay, so here what happens, you will have the skin surrounding the contents of the brain, but in anencephaly the brain is exposed to the external environment. Okay, so these are the three conditions which are seen on failure of closure of the anterior neuropore. You will have the anencephaly, enencephaly, and encephalocele. Now what will happen if there is failure of closure of the posterior neuropore? So you will have a condition known as the spina bifida. Now spina bifida can be of two types. One is the open spina bifida and one is the closed spina bifida. So let us come to the closed spina bifida, that is the skin covering will be present here. What will happen? The skin covering will be there, and this condition is known as the spina bifida occulta. Okay, so the dorsal arch of the vertebra will not develop, but things will not protrude out. Okay, and you will only get a tuft of hair. There is no much symptoms. The person will grow normally, but you might have a typical patch of hairy patch on the back, that is known as the spina bifida occulta. Then in the open spina bifida, you have two types. One is the meningocele and one is the myelomeningocele. In the meningocele, as the dorsal arch will not develop from the vertebral column, you know, this entire contents of the meninges will protrude out, but the spinal cord will not protrude. Okay, only the meninges will protrude out with the CSF. So you have the condition known as the meningocele. So only protrusion of the meninges. But in myelomeningocele, what will happen? Along with the meninges, you also have the spinal cord protruding out. Okay, so myelomeningocele, it is more severe form because along with the meninges, you also have the spinal cord protruding out. Okay, and in occulta it is less severe, and mostly you will see no symptoms here because you will only have a tuft of hair and everything is normal, but the arches are not developed. So if you see this this vertebra, as you can see, this is the body of the vertebra, these are the transverse process, and you have the spinous process. Now the spinous process is formed by the fusion of the dorsal arch. So if there is no fusion of the dorsal arch, the vertebral foramen contents will bulge out. Okay, the vertebral foramen contents will bulge out, and this bulging out is all known as the meningocele and myelomeningocele. So in the meningocele you will have only the meninges and the CSF, and in the myelomeningocele you will also have the spinal cord. So as you can see here, in the occulta means hidden, you will only have the tuft of hair. Okay, the vertebral arches are not developed. Okay, but the contents of the vertebra are intact, nothing is protruding out, only the arches are not developed. So this is the spina bifida occulta. Occulta means hidden. Now what will happen in meningocele? The contents of the vertebral column will protrude, but the spinal cord will not protrude, only the CSF will protrude along with the meninges. So this is the meningocele. And in the myelomeningocele, what will happen? Along with the meninges, the spinal cord is also protruding out. So meningomyelocele or myelomeningocele, it is more severe, right? Now we have another condition that is known as the craniorachichisis. Okay, so it is composed of two words. One is the craniochisis and one is the rachichisis. So if the brain is not developed, okay, and it is exposed to outside environment, that is known as the craniochisis. And if the entire neural tube is exposed to the outside environment, it is known as rachichisis. And condition of these two, that is anencephaly and spina bifida, okay, it is known as the craniorachichisis. And this shiny thing is the leaking of the CSF outside. This is the most severe form of your neural tube defect, that is the craniorachichisis. So you will have the anencephaly and you will also have the spina bifida. So let us come to the question, what is the embryological basis of the congenital anomaly? So this is a case of your anencephaly, and you know that anencephaly is your non-closure of your anterior neuropore. Okay, anterior neuropore. So this will be the correct answer, non-closure of the anterior neuropore. If there is non-closure of the posterior neuropore, then you will have your spina bifida, and non-closure of the entire neural tube, that is your rachichisis. Non-closure of the skull bone, again it is anencephaly. But what will happen here, they have not mentioned properly about the neuropore. So the better answer will be your anterior neuropore. Okay, non-closure of the skull bone is okay, but you have to also mention about the neuropore. So the better answer will be your non-closure of your anterior neuropore. Which of the following condition is shown in the picture? So as you can see here, in this region you can see the tuft of hair and no bulging, nothing. So by seeing this, you know that this is hidden, that is spina bifida occulta. Okay, so this is non-closure of the posterior neuropore. Okay, so the answer is your spina bifida occulta. Next, you can see both anencephaly, you have anencephaly, and you have your spina bifida. So this is a condition of your craniorachichisis. Okay, it is a condition of your craniorachichisis. So this is an image of your craniorachichisis. I think it is clear to you about the neural tube defect. Let us come to the next question. That is, an injury to the mark area can lead to the fracture of which bone? So they have given the options: scaphoid, distal end of radius, lunate, and first metacarpal. So before attempting this question, you should know what is this area called. This area is known as the anatomical snuff box. Okay, it is known as the anatomical snuff box. Now, what is the boundary of the anatomical snuff box? So you can see that laterally you will have the tendon of the abductor pollicis longus and extensor pollicis brevis, and anteromedially you will have the tendon of your extensor pollicis longus. So those are the boundaries of the anatomical snuff box. The floor is formed by two bones. One is the scaphoid bone, and you will also have the trapezium bone. And if there is injury to this anatomical snuff box, like fall on an outstretched hand, then you will have the scaphoid fracture. There will be avascular necrosis of the scaphoid bone. Now, what are the content of your this anatomical snuff box? The main content is your radial artery, and in the roof you will get the cephalic vein along with the superficial radial nerve. So those are the questions which might be asked again regarding anatomical snuff box. So the answer here will be your fall on an outstretched hand will lead to your scaphoid fracture because it is forming the floor of the anatomical snuff box. Okay. Next question is, if the mark area of the brain is involved, then which region of the body will be affected? They have given the option: brain and neck, trunk and leg, trunk and arm, and perineum and leg. Now you should know this is the medial surface of the brain. You get oriented first. As you can see the cerebellum here. So this is the posterior, this is the anterior aspect. Now what is that area? This area is known as the paracentral lobule. Okay, it is known as the paracentral lobule. So before going into the paracentral lobule's function, you should know about the homunculus, the sensory homunculus and the motor homunculus. So it is a neurological map of the motor and sensory functions of the body, and you mostly have your inverted homunculus in the body. Okay, inverted homunculus in the body. So as you can see the sensory areas, okay, you can see from the medial to, if you are going from the medial aspect, you will have the foot first, okay, then leg, then trunk, head, shoulder, hand here, lateral aspect, then you are having face, and then jaw, tongue, and pharynx. Similarly, motor also mostly similar. You have foot, leg, trunk, shoulder, hand, thumb, neck, and then face, tongue, swallowing. These are the homunculus areas. Okay. Now this paracentral lobule, if you see, it is mostly located in this area. Okay, in this area, and you know that this area, the homunculus, if you see both in sensory and motor, it is mostly related to your leg and foot and the genitalia, right? The genitalia, leg, foot, and genitalia. So you know that this will involve mostly the leg, foot, and the perineum region. And this paracentral lobule, it is mostly involved in your micturition and defecation. Okay, micturition and defecation. Okay, the main function, it is in the micturition and defecation, paracentral lobule. Okay, so any lesion in this area will lead to weakness and loss of sensation in the contralateral lower limb, that is paraplegia. Then you will also have urinary incontinence and fecal incontinence. Okay, so that is the functions related to the paracentral lobule. It is mostly concerned with your micturition and defecation. And if you see the sensory homunculus and motor homunculus, this area is mostly related to your genitalia, foot, and leg. Okay, so coming back to this question, this is the paracentral lobule involved in micturition and defecation. Okay, and the area which is going to get affected will be your perineum and leg. So the answer will be your perineum and leg. Okay, with this I end today's session, that is the image based session. I hope you understood well. Any doubt you can ask me or contact me. So regarding all these questions, I want to tell that mostly the questions are repeated, and on the image based side they are asking repeated questions. So I ask you to go through this previous year's questions so that you can get an idea of what type of questions are repeated, and in the same way or in a different way they are putting these images. So I hope this session helped you. Thank you very much.